Good evening, everyone. Thank you for joining in for this MUS webinars teaching sessions. And today we are having a very interesting topic that is, ultrasound imaging in radial wrist pain. This is something which we are often, referred for ultrasound. And today Dr. Akshay Sada, he's going to be talking on this, uh, this topic. I think I have heard this talk before, or maybe a part of this talk before, and he has some really fantastic cases to show. So I think without wasting too much of time, Akshay, why don't you start? The stage is yours, and please introduce yourself as well.
Thank you so much, sir. So, good evening. I'm Dr. So I'm very fortunate that I did that UCAM course and learned from all the stalwarts, and really happy. Just tenosynovitis. You can hear me, right? You can see the screen.
Yes, we
Yes,
can
we
see
can.
the screen. Yeah.
So one of the most common indications that we have is pain around the radial styloid. Now, when it is pain on the radial side, the most common thing that we see is the decurving tenosynovitis. So what does the clinician do? He does the Finkelstein's test. So you have a fist, thumb in your fist, and you do an ulnar deviation. So you get an excruciating pain on the radial side of the wrist. So once you have done this and there is severe triggering of the pain on radial side, the clinician knows that this is a decurving tenosynovitis, and you get a requisition saying USG for decurvings. So it is not the USG wrist, it is USG for decurvings. The clinical diagnosis is already done. So what we are supposed to do in these cases? So that's what we're going to see in the coming slides. So first thing, is it really decurvings? If the answer is yes, it is decurvings. So let's discuss about that first. So what is it? We have 6 compartments, extensor compartments. So the first extensor compartment comprising of abductor pollicis longus and extensor pollicis brevis. So this is the site of radial styloid. And you can see this is where these first compartment tendons rests on the bone, and then they go in forms the border of anatomical snub box and extend towards the thumb. So this is what is related to the decurving tenosynovitis. What is it? The tendons that we see are surrounded by an extensor retinaculum. So on ultrasound, you will see the 2 tendons resting on the radial styloid and covered by a very thin hypoechoic extensor retinaculum. So in the normal subjects, this will be seen as a very thin hypoechoic band. What happens in decurvings is that you get severe inflammation or severe thickening of the extensor retinaculum. So what happens is, because of chronic overuse, you get low grade chronic microtrauma at the level of radial styloid, and this leads to the localized thickening of extensor retinaculum. So because the extensor retinaculum gets thickened, this is a fibroosseous tunnel, and these first compartment tendons run through this fibroosseous tunnel. Because the extensor retinaculum has got thickened, the tunnel decreases in size, and that's why it causes that inflammation and impingement of the abductor pollicis longus and extensor pollicis brevis. That is the basic pathology. Now, usually we call it decurving tenosynovitis, but actually on pathological examination, you don't have any signs of inflammation. What you actually have are the signs of degenerative changes like mucoid degeneration, fibrocartilage metaplasia, mucopolysaccharide deposition, and neovascularization. So instead, the term that usually used is decurving disease and not decurving tenosynovitis. So usually patients present with the wrist pain, which might develop gradually or it may appear suddenly. So the pain is over the wrist joint near the base of thumb, and it radiates towards the thumb as well as into the proximal forearm. The other symptoms that you may get are the aching sensation, which are progressing to the point where any movement of the wrist is not possible. So initially you may get just a little bit of pain. There is no restriction, but gradually there may be severe restriction of the movements as well. And associated, there may be numbness at the back of the thumb and index finger. This is also called mommy wrist because it's often seen in new mothers because of repeated extension and flexion of the wrist with abduction of the thumb against the resistance because of whenever they are trying to grasp and lift the baby. So sometimes it's called baby wrist or mommy wrist as well. So what happens is we had seen the normal retinaculum, which was very thin, hypoechoic-like thing. So the first thing, the most important thing that happens in decurvence is there is significant thickening of this retinaculum. So you will see a thick hypoechoic band which is surrounding these two tendons. So a significant hypoechoic thickening of this retinaculum is the first and important diagnostic finding of decurvence. So that's the thickening of retinaculum. The next thing that you get is because there is thickening and there is inflammation, there is thickening and restriction of the tendon movements, you get thickened tendon as well. So as you can see in the normal asymptomatic side, these are very flat oval shaped structures. But in this condition, along with the thickening of retinaculum, the tendons become bulky and round. So there is significant tendon thickening. So these are the two things that you usually get, and you know that this is decurvence decurvence disease. So sometimes they can be bilateral. So in both the sides, you can see this thickening of the retinaculum and bulky rounding of the tendons. Now, like in any other tenosynovitis or any other inflammatory changes, the associated findings that you will get along with the retinaculum thickening and tendon thickening is you will get fluid, peritendinous fluid. Now, as you will see the anatomy, the tendons run on the surface of radial styloid. Then there is some space as they run over the scaphoid bone, and then they go on to the thumb or metacarpal. So they act as the bridge between this radial styloid and thumb. And this bridge, it has got some loose tissue. So any fluid accumulation that's going to happen in decurvence, it's going to happen in this free space. So at the level of radial styloid, what you will get is thickening of the retinaculum and tendons. And little distally, what you will get is the peritendinous fluid. Again, there will, because of neovascularization, there will be significant increased vascularity. These are all the typical findings that you will get. Along with that, if you do a dynamic scanning, there will be significant restriction of the tendon movements. Initially, there may not be significant restriction, but as the disease progresses, you will see a restriction of the tendon movements. And the first two things that we had seen earlier, along with all these findings, we know that this is decurvence disease. So the diagnosis, which was already done by the clinician, we have just confirmed it with extensor retinaculum thickening, tendon thickening, peritendinous fluid, increased vascularity, and restricted tendon movements. So what we have done is we have just confirmed that, okay, yes, it is decurvence disease, but have we added any further information? No. The reason why the patient is referred to us is to give us any more of the information that usually clinically they do not know. So what is the extra information that we are supposed to give is the first thing is if there is any anatomical variation. So what is that anatomical variation? That is the septum between these two tendons. Now, what we see is the two tendons are seen in the single tendon sheath and surrounded by the retinaculum. But sometimes what will happen is you will see a septum between these two tendons. So these two tendons will be seen in a separate tendon sheath. And that will be seen as a vertical hypoechoic band completely separating the two tendons. So this is very important information that we have to give in our report because that is going to add to the treatment part. So as we can see here, again, there is all the findings or thickening of the retinaculum and there is a hypoechoic band between the two tendons. So that is septum present. Now, sometimes it is not mandatory in all the cases, the thickening will be along both the tendons. There may be an isolated involvement of extensor pollicis brevis tendon only. So you can see this is APL, this is EPB, it's a vertical septum between the two tendons. And the thickening is seen only along the extensor pollicis brevis tendon. So this is an incomplete decurvence disease where isolated extensor pollicis brevis is involved. So it can involve both the tendons and sometimes it can involve only one tendon. And this is not uncommon. This is in fact very commonly seen. So that's the thing. It's only one tendon that is involved and APL is spared. Again, one more case where you have abductor pollicis longus normal. There is no thickening seen along this tendon and there is significant thickening seen along the brevis tendon. Now, septum is not necessarily seen always at the level of radial styloid. So the findings that we have seen so far are at the level of radial styloid, because that's where the tendons get entrapped and that's where there is stenosis for the tendons. The septum, if you don't see at the level of radial styloid, it's not necessary that it won't be present. Sometimes as you go little distally, the septum may be present distal to the radial styloid or distal to the tunnel. As in this case, you can see at the level of radial styloid, there is no septum seen. But as we come more distally, there is a septum seen between the two tendons. So septum, it may be present proximally at the level of tunnel, it may be present distally. Sometimes you can have a bony prominence. It's not just the fibrous septum, but there is associated a strong, prominent bony prominence which may separate the two tendons. So there are different types of classifications of the septum, just to know the types. So type 1, there is no septum. Both the tendons are seen in the same sheath. Type 2 is there is complete septation between the two tendons. Type 3 is incomplete septations, the one that I showed earlier, that they have same tendon sheath proximally and only distally there is a septum noted. And type 4 is EPB lacking type. Another classification is more simple. It is no septum, the septum present only distally and septum present only proximally. So the point is we have to look for the septum if it is present between the two tendons. It's going to matter also to change the treatment type. Another anatomical variation that is very important is accessory tendon slips. So these are the two tendons that we see, but sometimes specifically for the abductor pollicis longus, we can have multiple tendon slips. So EPB is usually one, but the APL, there may be 2, 3, or 4 tendon slips associated with that. Now, they may be difficult to differentiate at the site of tunnel because there is crowding, but they are easily identifiable once you go more distally towards that at the level of scaphoid, because that's when these tendons separate a little bit as they go to insert on different locations. And that's when we are actually able to identify if there are different or multiple tendon slips. Now, this is important at the time of surgery also, because when they do on-table maneuver and test the tendons, if there are multiple tendon slips which are not reported, they may mistake it for EPB and EPB may not be released at all. So that's why if there is any accessory tendon slips, how many tendon slips are there, they should be mentioned in our report. So in this case, you can see there are 2 tendons of abductor pollicis longus and there is 1 tendon of extensor pollicis brevis. So this is one second thing that we have to tell them. So these are the 2 anatomical variations apart from the diagnosis of De Quervain's that we have given. If there is septum present or not, and if there is accessory tendon slips present or not, this is one additional information that we have to provide in our report. So after diagnosis and anatomical variations, we come to the complications related to the disease. What we can have partial tear because of repeated trauma. Sometimes if the trauma is more severe, along with the thickening and inflammation, what you can have is partial tear. After surgeries, patient may come with the tendon subluxation. If there is excessive release of the extensor retinaculum, the APL may subluxate anteriorly on dynamic scanning. So there may be instability of the abductor pollicis longus. So in these cases, we have to tell them the exact if there is any tendon subluxation present or not. So these are the 2 complications related to the De Quervain's disease. So this completes our examination of De Quervain's disease. First, diagnosing all the findings, anatomical variations, if there are any present, and if there is any complication related to that. That completes the De Quervain's disease. Now coming to next, differential diagnosis. So coming to the first question, is it De Quervain's tenosynovitis? The answer, if the answer is no, the patient has come to us with the pain on radial side and there is no De Quervain's tenosynovitis. So if not, then what else it can be? And that's where our search begins, that what is the cause? Now, what can be the reasons for the pain apart from De Quervain's? So it depends on, we have to look at all the structures. So what are structures that we have in this region? We have superficial radial branch. We have the tendons, first, second, third compartment tendons. We have carpometacarpal joint and we have artery, that is radial artery. So the pain may be a little proximal to the site of first extensor retinaculum. It may be related to the superficial branch of radial nerve. We may have proximal intersection where the first compartment tendons crosses over the second compartment tendons. If we go a little more distally, we may have first carpometacarpal joint osteoarthritis. There may be pathologies related to the radial artery like radial artery thrombosis, pseudoaneurysms. If we go a little more medially or dorsally, we have distal intersection. And any space occupying lesion in this region may also give rise to the pain. So apart from the first compartment tendons, all these structures on the radial side mimic de Quervain's tenosynovitis, and we have to search for that. So let's see the cases, how we can see that. So again, this patient came with the pain on the radial side, and clinically it was de Quervain's disease. So first thing that we see, the first compartment tendons were absolutely normal. So what we see, the advantage of ultrasound that we always learn is that we can put the probe where it hurts the most. So actually the patient is in front of us, so we can see where the patient has maximum pain, and this was the point where the patient has maximum pain. So this is first extensor compartment crossing over the second compartment, but there is no thickening. But what we could see is the hypoechoic thing sitting on those, and it is giving the pain. If we compare it again, one more advantage of ultrasound, we can always immediately compare it to the opposite side. So most of the cases that I'll show, we have comparison on the opposite side. So the structure on the opposite side is absolutely normal, thin, flat, hyperechoic, and this is bulky. So this is a thickened superficial branch of radial nerve. So a long segment thickening right from the distal forearm up to the wrist, we have diffuse thickening hypoechoic ecotexture of the superficial branch of radial nerve. So you can see that in this video. Keep a watch on this nerve, and as you can see, it starts thicken. There's long segment thickening. Normally, it is very flat, thin. It is hardly seen. A very thin hyperechoic structure that is seen. So that's Wartenberg syndrome. So the closest differential for de Quervain's, or the condition which presents exactly like de Quervain's, is the pathology related to the superficial branch of radial nerve. So it's a neuropathy affecting that branch. The common etiologies are usually because of trauma or due to some iatrogenic events such as intravenous infusions. There may be entrapment of the nerve. The nerve originates at the elbow from the radial nerve. It traverses beneath the brachioradialis, and just 8 to 10 centimeter before the level of wrist, it pierces the fascia and comes superficial. So at that point, it runs between the brachioradialis and extensor carpi radialis longus. So this is the point where it may get entrapped and give us the symptoms of neuropathy. So the most common activities where we may get this kind of symptoms is the severe pronation. So the point where you have severe pronation and ulnar deviation, that's when this nerve gets entrapped in that point. So the reason why we may have that, because of increased tension, because of repeated movements of pronation and ulnar deviation, you have increased tension on the nerve, which causes ischemia and local inflammation. That was the reason, that was the cause in my case, where there was long segment thickening of the nerve. So it is now again this diagnosis, we can have an ultrasound guided corticosteroid injections at the site of tenderness. So it can be used as a treatment part as well. So one more case where there is a lump, a very small swelling lump on the radial side of the wrist. You can see that's a cyst right next to the cephalic vein, an anechoic thin walls, very small cyst. But if we trace that, it is sitting right next to the, or it is sitting on the superficial branch of radial nerve. So if you see this video, you can see, just keep an eye on this. This is the superficial branch of radial nerve, and here that cyst pops up, and this is the continuation of the nerve. So a ganglion cyst arising from the nerve sheath of the superficial branch of radial nerve, which was compressing on the nerve because of repeated movements, and that was causing the symptoms. So any pathology related to the superficial branch of radial nerve will exactly mimic that of the clinically, it will mimic the de Quervain's disease. Coming to next, again, put the probe where it hurts the most. So patient had pain on the radial side of the wrist, but where exactly? It was a little cranially, a little more dorsally to where we get de Quervain's disease. So as on the right side, it is absolutely normal. You can see the second compartment tendons, and these are the first compartment tendons crossing over. Whereas on the symptomatic side, there is significant thickening of the tendons. There is peritendinous edema. So this is the site of proximal intersection. So proximal intersection is where the first compartment tendons will cross over the second compartment. Clinically, if we see, the symptoms for de Quervain's are more on the radial side, and for intersection, they are slightly more proximally and on the dorsal side. So that's your normal asymptomatic right side. You can see the first compartment tendons. This is the second compartment smoothly crossing over, and there is no edema, no thickening, no inflammation. If we go to the symptomatic side, there is significant thickening, bulkiness of the tendon. You can see the peritendinous hypoechogenicity in the first compartment as well as second compartment tendons. And this was actually the site of pain. So that is proximal intersection syndrome, a little more proximally and dorsal to what we get in the decurvence. So it's due to repeated irritation because of extension of the wrist. So where second compartment tendons are crossed by the first compartment tendons. The next one is related to the joint. So a little more, again, very close to the radial or radial styloid, but a little distally. Because of chronic overuse, you may have first carpometacarpal joint osteoarthritis. We may see all the typical findings like periarticular soft tissue thickening, there are osteophytes, there is increased vascularity. So this is again one very close mimic of the pain on the radial side. Now, the osteophytes, they may be seen as a very small cortical protrusions, or there may be very frank osteophytes or loose bodies seen around the joint. We may see erosions on the bony surface. Along with the osteophytes, the other diagnostic features that we get are all the features of inflammation, like you have synovial thickening, you have increased signal on the power Doppler. So all these features we know that typically associated with the first carpometacarpal joint osteoarthritis. There's one more case where we have the peritendinous hypoechoic thickening. There is osteophytes seen. There is significant echoes in the joint noted. Then the swelling. Patient comes with the swelling on the radial side of the wrist, and it causes severe pain. So the most common space occupying lesion that we call in the wrist are ganglion cysts. So we can see an anechoic cyst sitting right next to the artery between the flexor carpi radialis and abductor pollicis longus. So that's a ganglion cyst. Usually these are cystic masses filled with viscous fluid and they lack synovial lining. They are well-defined anechoic structures with posterior acoustic enhancement, and always they are very close to the joint because they come from the joint capsule or through the joint. They can be dorsal or they can be ventral. The deep-seated ganglion cysts on the dorsal side are usually more painful. They always, or most of the times, they come from the scaphounate ligament. And because they distend the capsule, that's when they are more painful. But as they become more superficial and come into the soft tissues, there is release of intracystic pressure and they are less painful. So the ones which are not palpable and they're deep-seated, they are more painful rather than the ones which are more superficial. Coming to the ventral ganglia, they are more on the radial side of the wrist, and they originate from the scaphotrapezium joint, and they extend towards the distal epiphysis of radius, where they may compress or displace the radial artery and superficial branch of radial nerve. So the radial-sided pain, the ganglion, they are usually from the scaphotrapezium joint, and the reason why they cause pain are because of capsular distension, plus they may compress some of the adjacent nerves. These are the cause of the pain for this ventral ganglia. We have to make sure that they are distinguished from the pseudoaneurysms of the radial artery, which is again common because of microtrauma or friction or squeezing of the artery against the tubercle of scaphoid. So this is a case where you have again the similar thing, a structure which is right next to the artery between the FCR and first compartment tendons, but it is not cystic, it is not anechoic. It's a hypoechoic thing which is in continuation with the radial artery. So it's a pathology related to the radial artery. It's a thrombosis of the palmar branch of radial artery. So typically the radial artery which runs through the anatomical snuff box, and the palmar branch, if it gets thrombosed, if there is any pseudoaneurysm, if there is any surrounding inflammation, it will be seen as a pain on the radial side of the wrist, and it may come up as a swelling, but we have to make sure that it's not a ganglion, but it's a radial artery thrombosis. Now coming to one more pathology where we have pain on the little more on the dorsal side, close to the thumb. As you can see, this is, so we'll go here. This is your extensor digitorum, that is fourth compartment. This is a extensor pollicis longus, that's your distus tubercle. And as we see extensor pollicis longus crossing over the second compartment tendons, there is significant thickening around the joint, around the tendon. There is fluid, the thickening of extensor carpi radialis longus as well as brevis. So all the features that we see, that we had seen in the proximal intersection, the similar features are seen in the distal intersection. This is the longitudinal section where you see the extensor pollicis longus crossing over these two tendons. There is significant peritendinous edema. There is increased vascularity, inflammation. So this is present more towards the dorsal and close to the thumb. The proximal intersection is a little more cranially in the distal forearm, but the appearance or the findings are the same. Now, if we have one pathology, now in this case, we have if we have one pathology, it is not necessary that we may not have another pathology. So in this case, you have decurvence tenosynovitis, which is exclusively involving the extensor pollicis brevis tendon. But along with that, patient also has thickening of the A1 pulley along the flexor pollicis longus. So actually, this patient came for the pain in thumb, and it was decurvence along with the trigger thumb. So if we have one pathology, it does not mean that we cannot have another pathology. So we have to check for all the symptoms, basically all the symptoms that patient has, all the conditions related to that symptom we can go for. So these are the differential diagnoses. Apart from decurvence, if we have a pain on the radial side, we can have any pathology related to the superficial branch of radial nerve. We can have pathology related to the tendons crossover. It may be proximal intersection, it may be distal intersection. Now, these present just like decurvence because you have pain on the movement and they are all on the radial side. Any space occupying lesion, it may have compression on the nerve or the capsule, and they may have pain. Any pathology related to the radial artery and first carpometacarpal joint. So all these are the mimics of pain on the radial side. Now, I've included this case. It doesn't cause pain as such, but it's a pathology on the radial side. So whenever you have history of surgery, you have a screw or post-operative material, and because of repeated microtrauma, there is an attrition tear of the extensor pollicis. So these patients usually come with inability to extend the thumb. There is no pain, but the pathology is on the same side. You can have a long tear of extensor pollicis longus. This is the long tear, and it's because of the screw. So you can have tear of extensor pollicis longus, or you can have tenosynovitis of extensor pollicis longus tendon on the radial side. Now, typically, when we have this tenosynovitis of EPL, the fluid accumulation is very particular because there is a narrow sheath at the level of listus tubercle. We don't see fluid at this level. The fluid accumulation is always a little more distally or a little more proximally, along with all the other features of tenosynovitis. If we go more ventrally, we can have flexor carpa radialis tendinosis. Now, it crosses over the scaphoid bone, goes through the tunnel, if we call it FCR tunnel, and inserts onto the metacarpals. So whenever there is thickening of this tendon, it gives a pain more on the ventral side and on the flexion and extension of the wrist. So we have thickening of the flexor carpa radialis tendon. There is underlying cortical irregularity of the scaphoid, and there is peritendinous inflammation. Here's one more case where you have, as it goes through the tunnel, the most common is as it goes through the tunnel, it causes. This is the asymptomatic side where we can see a smooth scaphoid, normal sized flexor carpa radialis is going beyond the scaphoid bone and inserting on the metacarpal. Whereas on the affected side, we have a thickened tendon with peritendinous thickening and underlying scaphoid irregularity. Now, apart from this, there are a lot of other conditions. I had these many cases, but there are some other conditions specifically related to the scapulohumeral ligament. There may be scapulohumeral ligament tear. We may have scapulohumeral dissociation. We may have DISI deformity. There are fractures related to the radial radius or styloid process. So all these can also mimic, but pertaining to the ultrasound and related to the soft tissues, the conditions that I have shown you, these are the most common causes. So to summarize, we have tendons where we may get pain on the radial side. This may be decurvence disease. It may be intersection syndrome. It may be extensor carpa, extensor pollicis longus tenosynovitis, or it may be flexor carpa radialis tendinosis. So all the tendons in that region can have pain. If not tendons, we may have nerves and vessels. So anything which is compressing the superficial branch of radial nerve has to be seen if it is not related to the tendons. Anything related to the radial artery, it may give symptoms or pain related on the radial side. After tendons and vessels, if these two things are absolutely normal, we may have osteoarticular pathologies like thumb carpometacarpal joint osteoarthritis. We can have scaphotrapezio, trapezoid osteoarthritis, scaphoid or radial fractures, and scapulohumerate ligament tear or dissociation. And lastly, we may have masses which may compress onto the adjacent structures and give the pain. Most common is ganglion cyst, and there may be some neurogenic tumors. Thank you.
Wow, superb, Akshay. So I think this is a really comprehensive, review of all the possible pathologies which can present with radial-sided wrist pain. So, we often discuss about ulnar-sided wrist pain, and most of the times we're dealing with, DFCC. That's when, we're covering these MR talks. But then we really don't discuss much about radial-sided wrist pain because, we always think, oh, it's only deeper vein stenosynovitis, and we feel it's quite easy. But yes, like what Akshay said, these are so many pathologies that we need to be aware of. So, if there are any questions, we'll be happy to answer. So one thing about superficial branch of radial nerve, we see that once in a while we see it post, radial artery catheterization. They do a lot of angiographies. So these are the times when the superficial branch of radial nerve does get injured. So once in a while we do come across that.
No, even with the cephalic vein cannulation, a lot of people do IV insertion to this vein, and that is one of the common cause of the injury to the, I think, sensory branch of the radial
Yes, that's
nerve.
one of the very common cause.
Common cause, yes. So Akshay, that was excellent presentation.
Thank you so
Excellent
much.
images, very nice images.
Thank you, sir.
Good.
Though I did not have the scapulohumerate ligament tear and dissociation, all those cases I did not have, but that is something that I would like to collect now.
Right. So ganglion is the one which is very scapulohumerate ligament is common side of ganglion, So they can mimic sometimes like a distal intersection syndrome.
Yes.
So that's and tear of the scapulohumerate ligament, particularly the dorsal segment. Of course, ventral part and the intervening part you cannot see it on ultrasound. The dorsal scapulohumerate ligament can be very well seen on ultrasound. Yes. Overall, good. You have covered all the pathologies. This is a common day-to-day practice.
Yes.
You have so many references, and ultrasound, I feel, should always be the first imaging modality, and it's good enough to diagnose.
Yes. So mostly I get whenever I get that referral, it's always like actually, as I said, it's written that it's USG for decurrence. So they send it, and sometimes very often it turns out to be something else. It is not always that it will have, and it turns out to be something.
Right. So you do have surprises,
Yes.
So,
very, very nice talk.
Thank you so much.
Thank you so much. Yeah. But one of the differential diagnosis will be, I think, lateral antebrachial cutaneous nerve.
Yes.
It's a distal branch of the median nerve, and it's very closely related to the cephalic vein, and it lies just above I think it's above the radial artery at the wrist level.
Yes.
So that can be compressed.
Yes. And they both have, there is an overlap of even the distribution. There is an overlap between the two nerves.
In terms will be overlap.
Yes, sir.
Okay. Ankit. Hello.
Should we
hello.
Ankit?
Yeah. Yes. There is one question. There's one question by Dr. Renu, that how do you differentiate between intersection syndrome and deeper vein stenosynovitis? I think she just would want you to explain it again.
Yes, sir. So decurrence is basically related to the first compartment only. So all the other compartment tendons are absolutely normal. The first compartment tendon, as it runs over the radial styloid, because of thickening of extensor retinaculum, it gets stenosed, and that's when you get that symptoms. The intersection is because of crossover of the tendons from one compartment with the other compartment. So usually we have two crossovers. The first compartment tendons a little in the distal forearm. The first compartment crosses over the second compartment tendons. So at that point where they cross over, that's when we get the changes of intersection syndrome. And after the crossover, once that first compartment tendons goes onto the radial styloid, that's where we get decurvence. So the site is little different, location is little different.
I agree. Yes, yes. I think that's very well explained. And sometimes it might be a diagnostic dilemma that, when there's decurvence, tenosynovitis, and the pain might be so diffuse that it actually radiates into the distal forearm. And
Yeah.
so that is it a possible, uh, proximal intersection syndrome or not? So it's a good idea to scan at that level also, even though the queries for decurvence tenosynovitis.
Yeah.
Great. So I think that was a fantastic session. Uh, Anybody has any more questions? If not, then I think we can conclude the session. Thank you everyone for joining. I think it was a short, although it was this time we kept the session a little bit short, but then this is a really, really important topic. So, and then we'll have the next set of uh, uh, webinars next month. So we're starting with sessions on regenerative medicine. We'll be covering various topics, and we'll be keeping you all updated regarding that. Yes. So thank you, everyone.